Hello, everybody. Welcome to UOA On Demand. This is a series where we discuss a specific topic, and today's topic will be total hip replacements. I am a joint replacement specialist at University Orthopaedics, and I'm joined by my two colleagues and partners who are also joint replacement specialists. I did a fellowship in joint replacements at the Cleveland Clinic. We're joined by Dr. Baione, who did his joint replacement fellowship in South Florida in Tampa, and Dr. Stephen Kayiaros, who did a adult reconstructive joint replacement fellowship at the Hospital for Special Surgery. So I think the first thing we should do is to present a patient that is an actual patient. I just saw her in the office today. I saw her for the first time a couple of months ago. This patient is a 62-year-old nurse. She's had pain down her left leg for the last 3 years, but it has gotten a lot worse over the last 2 years. So she came to me as a consultant and wanted to know some advice and what she thought she had. So her complaints were basically, she didn't have a lot of pain when she was lying in bed or even sitting down, but when she put her weight on it, the pain was primarily in her groin and radiated down her thigh. Initially, she thought it was a groin pull, but instead of getting better, it got worse and worse over the years. And she also has difficulty putting on her shoes and socks. She noticed that her range of motion is on that hip to get down to her shoe and sock has become more and more limited. So she can do it, but it's very difficult. She has more and more difficulty with her job as she stands most of the day. And so when she came into the office, we took an x-ray and you can see the x-rays that she had at the time of her office visit. So Dr. Baione, what would you say that this patient suffered from, and what is the diagnosis?
Well, the thing that's interesting is that you can often make the diagnosis just based on the history that you've provided. And, once you're able to review the radiograph, it often confirms that. And the thing that always surprises me is that people don't think of their groin as being their hip. They always think of the hip as being this lateral posterior structure. And so the history is very classic for arthritis in terms of how you presented it. So when you look at her radiographs and you evaluate for things that we try to look at in terms of how much of the joint is preserved and how much is left, you can see that she has a complete loss of the superior joint space. She has thickening of the bone underneath where the cartilage would have been. There's some bone spurs around the edge of the hip. And so this is the appearance of a hip that would be considered severely arthritic. And the history that you provided, I think, is consistent with this x-ray. And so it's, sort of end stage osteoarthritis.
So that's what I told her. And the next thing that she said to me, though, was that, oh, but doctor, I don't want surgery. So are there things that you can do to make this better and and allow me to work with less pain and continue to function? So, Steve, Dr. Kayiaros, what would you answer to a patient like that?
Yeah, so there's several conservative treatments that we can offer patients to try to get them some pain relief. Certainly, trying some physical therapy, maybe a cortisone injection. Trying some anti-inflammatories, modifying their activities. Someone who's a nurse and who's can't is working all the time and may not have the time to go to physical therapy. And I don't know how what you guys have found, but certainly I've seen anecdotally if a patient has a really bad hip, sometimes you send them to therapy and they'll get worse. Not to certainly there's always a time and a place for physical therapy, but a really symptomatic hip will just not respond to therapy. Or if you give them a prescription to get a cortisone injection, sometimes they'll get like 3 great days of relief and then they're back to where they were beforehand. And so, depending on their symptoms and their exam and how bad their arthritis is, sometimes I'll try to steer them away from conservative treatment to get their hip replaced, unless there are other factors that would prevent that from happening. I'd be curious to see what you guys think about that.
I tend to agree with some of what you said there. I think there is definitely a situation where on the surface, it makes sense to go to therapy to help strengthen the muscles around the joint. But if the joint is very painful and it hurts to move and it hurts to bear weight, I have seen patients sometimes struggle with that intervention. And then the other intervention that you mentioned was getting a cortisone injection. And for those in the audience, this is a specific injection that's given into the joint space. It's typically done under X-ray or ultrasound. And I think that when the hip is not severely arthritic, patients tend to get more relief. But when you're end stage, bone on bone, the amount of relief that patients tend to get from that injection can be limited. And one of the factors that as joint surgeons we often have to deal with is the potential risk for infection. And so sometimes doing an injection that you don't think is going to give them much relief, but gives them a risk factor for potential infection, I try to avoid that when someone is end stage like that.
Yeah, I think that's right, Will, and I agree with both of you guys. The other thing about it is that if she came to me, even with the same X-rays, but if she came to me and had 3 months of pain, then you might be more likely to reach out to other modalities. But with 3 years of pain getting worse and worse, more likely to think about doing something more definitive. But since this discussion is about total hip replacements, I think the next step in tonight's meeting would be to describe, well, what is a hip replacement? Patients, sometimes they don't know what a hip replacement is. They hear about it all the time, but what is a hip replacement? So Will, why don't you tackle that? I think we have some pictures too.
Sure. So if you look at the diagram, it's basically a schematic of the parts that make up a hip replacement. When you break it down, there's essentially 4 pieces. And the goal of the operation is to replace the worn out cartilage. So it's essentially a resurfacing procedure. So the metallic parts or the parts that you see that are the cup and the stem that would sit within the femur, those components are typically made of metal. Historically, the original replacements were fixed to the bone with cement. More commonly in today's hip replacements, these are cementless implants that are coated in a material that the bone will grow into. This serves as the anchor point to the body that will support the new joint. And then the other 2 parts of the hip replacement are the new ball that you're going to place onto the hip. And then the thing that's probably mostly debated is the bearing surface, what is going to go inside of the cup. And so the traditional bearing surface was polyethylene, which is a plastic. And what I often tell patients is that years ago, the plastics were not as good as the plastics that we have today. And a lot of that's based on the advances we've made in material science. And so you mentioned earlier that this patient is 62 years old. And so maybe 20 years ago, even if she had the same diagnosis, I think there was sometimes a concern for doing joint replacements on younger patients if you thought that they were going to wear their plastic out, needing potential new operations in the future. So,
well, funny you should say that, Dr. Baione, because the other thing that she eventually told me is that she did see another surgeon about 2 years earlier, and who made the same diagnosis. But his admonishment was that although she could benefit from a total hip replacement, that she was too young. And so she took that to heart and was avoiding hip replacement at all cost. So although Will mentioned it a little bit, what do you think about that concept, Steve, or people being too young to get the benefit from surgical options?
So yeah, I think that historically that was something that I think orthopedic surgeons would tell their patients just because of prosthetic longevity. But I think in 2020, with the materials that we have and highly cross-linked polyethylene, I don't think that that's an issue anymore. I mean, there's no reason for patients to really be in pain. And I think that the literature, both on the clinical side and the laboratory side with, simulator data, shows that, the wear on these implants is almost negligible. And the problems the problems of the joint replacements of 2 decades ago with, bone loss and loosening and osteolysis, I don't think we're going to see those problems 10, 20 years from now, at least not see them as much as we did with previous joint replacements. So I think today, I think, quality of life and not being in pain is at the forefront. And I think we can confidently, do these surgeries on patients and confidently tell them that it should last them for the rest of their lives.
I think that's an important take-home message for people watching, watching this episode, because it's been pretty well established in the past that surgery is the last resort because these things would wear out. Now it's still the last resort, but it's a pretty good last resort, and I don't think we have to limit it to just older people who have limited lifespans. Apropos to that, the other thing that she told me was that in her desperate search for some treatments, she went to another doctor, not a surgeon, but a doctor who recommended stem cell injections. And so she got stem cell injections where they took some material from her pelvis bone and did something with it and re-injected it into her hip. So not only didn't it help, but she was charged $5,000 up front that the insurance company didn't pay for. So what would you gentlemen think about any consideration of stem cell injections?
I mean, I think when you look at the idea of stem cells, it's attractive to patients because they think that if you have a primordial cell that hasn't turned into the definitive tissue that it will become, the idea that you could somehow grow cartilage is attractive. The problem is the basic science of getting cartilage to grow on a petri dish and getting it to grow within a degenerated joint. I think there's a large gap in that in reality. And so the amount of relief that patients get from an injection like that, I don't think it actually regenerates cartilage in the joint. There's probably some anti-inflammatory property that they get from it. But I think sometimes it's advertised in a way that gives a false promise that somehow it's going to change the appearance of the X-ray and provide relief. And I don't know that the basic science for the indication of osteoarthritis has proven benefit. I think there are some applications for those types of injections in other parts of the body for different indications, but for a severely degenerated joint, I usually tell patients, in all honesty, it's a waste of money, and I tell them to avoid it.
Yeah, I agree with that, and I'm sure it's done by well-meaning physicians, but from our perspective, it seems a little unfair to try to capitalize on patients' fear of the surgical procedure that would actually benefit them and veer them to treatments that are expensive and are not likely to work. So I would also agree and steer people away from that. So then we discussed the possibility of the hip replacement, and she wanted to know, okay, well, what could go wrong? What are the potential issues? Is it scary? Is it painful? So Dr. Kayiaros, what do you tell patients when they ask you these kind of questions?
Well, it's I usually discuss kind of the most common things that can go wrong after hip replacement. Certainly infection is always a concern. Dislocation, or the hip popping out of the socket. Blood clots can happen after surgery. There could be a fracture around the bone, either during the time of the surgery or afterwards. These are the sort of things that can happen, early on. Certainly the long-term, risks of the implant wearing out are sort of inherently there. But I tend to focus the conversation on the things that are most likely to happen in the in the first month or two after the surgery.
Yeah, I think that's right. And although those things still sound scary and we still have to explain it to patients, I think it's also important to at least give them the impression that these are relatively uncommon events. And when they do happen, we can handle it. Because it's to me, it's a balancing act between, informing patients, but also not scaring them away from the surgery that they could benefit from significantly. Are there any times, Will, that you would see a patient and you would recommend some other physical things that they would do to optimize themselves before the surgery?
So, I mean, there's things related to their medical
the
health. And
surgery.
so you have their orthopedic issue. And so anything they can do to maintain their mobility. We had touched a little bit on physical therapy before. So yes, that's an option for some patients. It's sort of a prehab, as we say. But in general, I would have them focus on, working on some mobility and strengthening. Now, if they have certain medical problems that need to be addressed in terms of optimization, one of the hot topics when it comes to joint replacement is, your weight and your BMI. And it's not so much the physical number of your weight, but that elevation in your BMI, in our literature, translates directly to an increase in your risk of having some of these complications, whether it's the wound infection, problems with the wound healing, difficulty with exposure, fracture. And so sometimes when you're talking to patients about weight, there's the mechanical part of losing weight to take stress off of the joint. But as a surgeon, I think sometimes we just want them to be as healthy as possible going into the surgery. And so sometimes that's a discussion you have to have where someone maybe is not ready for surgery, but you tell them that this is coming and you should get healthier before you get in a situation where you need the operation and it's going to be difficult to proceed.
Yeah, I think that's right. And at least in my office, it's a very hard thing to discuss, because the patients are coming, for help orthopedically, and then you're telling them that they need to do other things at a time when they're not really able to exercise to help lose the weight. So it's a real tough thing. If patients are significantly overweight, though, I think that has to be stressed. And just also, if you're one of those patients, just realize that we're not doing this for anything but your own health and your own benefit. And we don't want to put you at any undue additional risks if we don't have to. And the other thing I would say is in terms of medical optimization. So things like weight loss, smoking, stopping smoking, it would be a big thing. But we also rely heavily on our medical colleagues. And so when we do, if you do agree to do the surgery, we also would definitely keep all of your medical people in the loop. We communicate with them the fact that we're going to go through this, we're planning on this procedure, and then they have the opportunity to weigh in to say, well, okay, fine, but maybe we need a stress test or give us some advice, as to what else to do during or after the surgery. So although there are risks, I think we bend over backwards to try to minimize the risks. We are dealing with people; they're not furniture. We do our carpentry on the people, but they are people that can have real problems. And, that's part of our job. And that's part of what, when patients agree to it, they understand there's some risks, but we really do try to minimize it. What about activities afterwards, Dr. Kayiaros? Like people Like they want to know if they have any limitations, temporarily and permanently. What do you tell them they can do, what they can't do after a hip replacement procedure?
Usually for the first 3 months, while they're recovering, the only thing I really want them to do is walk. Even though they may feel great and they're out of pain and they're eager to get back to the gym or yoga or golf or tennis. I've had instances where patients can have setbacks. They try to do a little bit too much, and then that causes some inflammation, and they start getting a little pain. So initially, I only want them to do the only thing I want them to do is walk. And then after that 3-month time period, I pretty much let them do kind of whatever they want. I mean, the only thing that I discourage is running or anything that's going to be high impact, just because that those activities could theoretically lead the implant to wear out sooner rather than later. Younger patients are going to demand more out of their implant, patients that want to be more active. And so I think to your point, Dave, in that, conversation before surgery, counseling patients appropriately and having, realistic expectations, and counseling them appropriately as to what they'll be able to do after the surgery, and having them understand that, the more that they do, the more demands that are going to be put on the implant. So running is kind of like the only thing that I discourage, but I have patients, golf, tennis, hiking. If they're skiers before surgery, I let them ski as long as they're careful. It's pretty remarkable what patients are able to do after hip replacement.
Yeah, I totally agree. It's one of the operations where most people feel pretty normal. It's not even just it feels better; it feels pretty normal. So it's quite remarkable. And in terms of running, I take it up as a sport. But I tell them also, if you're in the middle of the road and a bus is coming, you can certainly, on short instances, you can certainly run out of the way. But for the most part, that's I think what they're allowed to do is pretty much anything other than the impact stuff. The other question that patients always ask, and you sort of touched on it a little bit already, is they'll say, so Dr. Baione, like, how long is the recovery? Like how long will I be limited? And usually, so in terms of like specifics, a lot of times they have specifics in mind, and the two most common things are getting back to work and driving. So what do you tell those patients?
I mean, I think that's a very important question. And one of the things that sort of allows people to be comfortable with the operation is setting expectations. And so there's a lot of factors that go into that in terms of how people recover from surgery. But I think total hip replacement has become very refined in that you look at an operation that many years ago, everyone stayed in the hospital for several days. The majority of people went to rehab. Our pain control metrics relied mainly on narcotics. And now we've boiled down the operation where in many instances it can be a same day operation or a short hospital stay of 1 day. And so patients are immediately weight bearing, they're mobile, and they can recover at home. And so what I generally tell people is after that short hospital stay of a day or two, they're home with pretty much no major restrictions. And that's a separate discussion that we could have talking about approaches and how the surgery is done. But in general, they'll be sore for a few weeks. And by the time they get to a month after surgery, the majority of patients are doing really well. They don't have a lot of pain. They're back to most of their activities. They're able to drive after a week or two in some cases. And so depending on the type of work that they do, if they have desk work or a sedentary job, they can often return pretty quickly within a few weeks. If they have a more strenuous job, sort of pigtailing on what Steve said before, that you don't want them to even if they don't have pain anymore, you don't want them to aggravate things. And so if you have a more strenuous job, I usually want you to recover before you go back to that. So I would wait the 2 to 3 months for some of those patients. And you have to tailor that discussion to each patient.
Sorry, Will.
Yep.
So Steve, how would you answer that question? The same way?
For the activity and driving?
Yeah, and the recovery in general, and what they can do in their
I tend to give patients general guidelines. I think it's helpful to kind of give them, like sort of check boxes, like, okay, I've reached my 1 week mark, or 3 week mark. So I tell them that by 2 weeks they should expect to be walking comfortably with a cane, and by 6 weeks, 8 weeks, they should feel like they're seeing the light at the end of the tunnel. For driving, if it's their right leg, I tell them no driving for 2 weeks. If it's their left leg, they can drive as soon as they're walking comfortably, and provided they're not taking a pain pill. For work, I tailor it to what their job is. If it's, like Will said, if it's something like a desk job, or something that doesn't require a lot of physical activity, I let them go back when they feel that they can do their job. If it's something more physical, someone in construction, I'm a little bit more on the conservative side, and I'll probably keep them out for probably 3 months, just because just the demands of their job. They really need to be fully healed.
Yeah, I think I have the exact same approach. I think we're on the same page. Just to circle back to our original patient, she eventually did get a hip replacement successfully. She stayed overnight, one night in the hospital, and then went home to recover at home, and was back to work in 2 months. So patients decide now that they want to actually go forward with the hip replacement. So they want to know, well, what's the next step? And so usually the first step is to put it on the surgical schedule, and we all have assistants that will do that. And usually the surgery is scheduled out at least 4 to 6 weeks, sometimes longer, but it's 4 to 6 weeks, which isn't unduly long, but it also provides the time to do those other things, like get checked by their medical doctors. So once the surgery is scheduled, when I first trained, the patients would be admitted the night before. You'd stay in the hospital for almost 2 weeks and then go home after that. But things are so dramatic. Over the last couple of decades, I've seen such dramatic changes in my career. So now the patients will go in the hospital, or even the surgery center, the same day of the surgery. They get the surgery, usually under a regional anesthesia, not even going to under general anesthesia. They will recover from the regional anesthesia and the surgery immediately, within 2 or 3 hours, get up and walk. So they're literally walking, usually full weight bearing, within a few hours of their procedure. Sometimes going home the same day, and at most usually staying overnight, one night in the hospital, and going home the next day. So I think there's a few reasons why we're able to do this. I think maybe, so Steve, can you think of some reasons and how things are different and why they're better? Because people want to know, is it better now? What happens that's different and latest and the greatest, especially with, the hip replacements.
Yeah, I think all those advancements has been, patient driven. Patients want to, we want patients to recover faster. We want to minimize complications. So we know that, doing the surgery under a regional block as opposed to general anesthesia is better. Getting patients up and walking immediately after the surgery improves their recovery, lowers their chance of a blood clot. getting patients out of the hospital as quickly as possible, or even in a surgery center, lowers the chance of an infection. So, all of these advances, which are evidence-based, are really driven towards, better patient outcomes, which is ultimately what we're striving for.
Yeah, I agree. And I think you're a bit modest. So I think part of what, how patients are doing like a lot better, quicker is the approach that Dr. Kayiaros brought to New Brunswick. And so now we all do this approach, at least in appropriate patients. Then not everyone is a candidate, but, and I wouldn't be afraid to go forward with the surgery if you're not, but the people that are, it's kind of remarkable how quickly they get up and move around and then are able to go home. So one final topic I think we should talk about is pain management, because that's part of, what we've done to get these people moving quickly. And especially in this, in this day and age where everyone's afraid of, the opioid epidemic is with us, and, everyone's afraid of that. So Will, what's your feelings about pain management in total hip replacement?
So again, tailoring on what you said before, I think how the operation's done, using a minimally invasive approach that really doesn't place many precautions on the patient, has allowed them to be a lot more comfortable. And when you couple that with regional anesthesia, I found that the anterior approach hip patients usually don't require a lot of medication. It's not uncommon for them to come even to their first post-operative visit saying that they only really took a pain pill or two. And so I think the change that we have made is that we look at multimodal pain, where we don't just rely on narcotic pain medication. I still provide it to the patients in a low dose with a few pills, so that when they go home, especially that first day or two, if they think they need something, they have it available. But I think I tend to focus more on anti-inflammatories and medications like Tylenol and other modalities such as icing. And specifically for hip replacement, I think that's enough for most patients. And so it's the reality that they really don't need to take many narcotics after a hip replacement for most patients. And if they do, it's only those first few days. So I think the risk of some of the things that people are concerned about, specifically with opiates and side effects and the epidemic, I think you can reassure them that they can recover pretty comfortably without having to take a lot of that type of medication.
And the idea of multimodal pain management is each one of those things you do, like Tylenol or, an anti-inflammatory by itself isn't enough. But when you put all those soldiers together, you have a pretty good fight. And although they occasionally will still need narcotics, it's so limited that the fear of becoming addicted is really non-existent, and we can get you through this, without a lot of pain. And then the pain from the arthritis also is gone immediately. So you're trading one bad pain for a milder pain, which we can manage. So that's mostly what I wanted to cover tonight. Do you gentlemen have anything additional that you don't want to mention or that I forgot?
I think that was pretty comprehensive and a good discussion, Dave.
Well, I would just like to reach out to our audience and conclude. And I think that the take-home messages are the fact that most people are candidates, and age doesn't really matter. If you get the hip replacement, because you need it, you'll improve your lifestyle. But also, unless you have some unusual, weird complication, we can expect it not to wear out in the vast majority of people, even in young patients. So there isn't a big reason to fear it. It also doesn't make as much sense as it used to suffer for years when you could have gotten the operation that would have helped you, and then you end up getting the same operation anyway. So you might as well do it, enjoy your life, and get back to it. We bend over backwards to try to do it as safely and as painlessly as possible. And the fact that now you mostly recover in the comfort of your own home, I think has been huge. So I'd like to leave it with patients that if they are concerned about their hips, even if they don't know what they have and would like to get it checked out, or certainly if they're hip replacement candidates, I would urge you to reach out to us at uoanj.com, and Dr. Kayiaros, Dr. Baione, and myself would be more than happy to take a look, offer advice, and hopefully help you.